Good afternoon. I see that folks are hopping on slowly. I know we're right sort of in the middle of lunchtime. Dr. Littlewood will be joining us momentarily. In the meantime, if you are on and joining, we always love to get to know who's on since we don't have time to do that through verbal introductions. Please feel free to introduce yourself in the chat. Please be sure that you're selecting everyone so that the whole group gets to see who's with us. Let us know who you are and where you're from, what practice or group you're joining us from, and welcome. We will be welcoming Dr. Littlewood in the coming moments and get started. So welcome again. I see a couple more folks have hopped on, and thank you if you've already introduced yourself in the chat. I see Dr. Abney and some other familiar names. Welcome. We're glad to have you here. Please feel free to introduce yourself and where you're from, what practice you're from, and what part of the state. It's great to see some familiar names, even though we can't see each other face to face. Dr. Littlewood will be joining us, and we'll get started in the coming moments.
Hello. Okay, success.
Hi, Alden. Welcome.
Hi, thank you. I apologize. That was tricky. I don't know what that was about.
No worries. I think that technology is mysterious. So thank you for joining us. We have folks joining slowly. So if you haven't heard me ask, we would really welcome all of our participants to introduce themselves in the chat. It's great to get to know everyone sort of virtually. I know we've been doing this for almost 2 years, but please let us know who you are and where you're from, what practice or what part of the state. I'll let Dr. Littlewood go ahead and share her slides, unless you would prefer that me do that, but I think I'll let you take control. And while Alden, while you're getting set up, I will just, some of you have heard this a lot of times, but we're Maryland BHIPP, and we really appreciate the chance to gather with providers from across the state once a month or so. And as a reminder, we provide consultation, and you'll see this pop up on one of Alden's slides in a minute, but I'll just say it now while we're getting settled. We provide telephone consultation, resource and referral support, training and education, and regionally specific social work co-location around Maryland. And so we're happy to support you as you care for your patients' behavioral health needs. So please feel free to ask us questions about that. And we're really pleased to have Dr. Littlewood join us today to talk about diagnosing and managing seasonal depression in the primary care setting. So Alden, I'll go ahead and introduce you while you're pulling your slides up, if that works.
So I have them pulled up. I don't have the ability enabled to share right now.
Okay. Hey, Chelsea, could you help with that?
Thank you.
Maybe it'll be in the 3rd year of the pandemic that technology runs smoothly for all of us. I was doing this last night on a meeting and not doing it perfectly seamlessly. So while Chelsea passes you that sharing ability, I will introduce Dr. Littlewood to our audience. So Dr. Littlewood is originally from New Orleans and attended medical school at LSU School of Medicine in New Orleans, and she completed her preliminary year of internal medicine at, maybe not going to say this right, Alden, so you can help me. Is it Ochsner Clinic Foundation in Jefferson? Okay. And her adult psychiatry residency at the LSU New Orleans Ochsner Joint Program. Most recently, she completed a fellowship in child and adolescent psychiatry at the University of Maryland, Sheppard Pratt. Dr. Littlewood performs child and adolescent psychiatry consultations for us at the Maryland BHIPP consultation team, and she's also part of the inpatient psychiatry faculty at UMMC Midtown. We're really privileged to have had her join the team this year. Some of you might have gotten a chance to talk to Alden. If not, you maybe will. So I will turn things over, and I'm excited to join her to talk some about therapy and brief intervention. So take it away.
Thank you so much. Great to talk to everybody. Thank you for being here. So I think Kelly has already kind of gone through who we are. So of course, today we're going to be talking a little bit about depression in general and seasonal depression specifically. So of course, our learning objectives for today, by the end of this 45 minutes to an hour, we want everybody to be able to feel familiar with how to screen and diagnose depression generally and seasonal depression particularly, differentiate kind of more serious seasonal affective disorder versus major depression versus kind of a more situational picture. Understand a little bit about managing that as well from the clinic, both from a pharmacological standpoint and a non-pharmacological standpoint. And then figuring out how to manage, of course, from the pharmacological perspective, what medicines are going to be recommended for this. So we'll start off talking a little bit about, so what is seasonal affective disorder versus seasonal depression and depression in general. We'll move on a little bit later and talk about how to go about assessing that in the clinic in a practical way and who to assess. And then, of course, we'll move on to treatment. So before we move on too much, I did just want to start us off with a case. So this is in a picture where we have a patient coming in December, so in the winter, a 15-year-old patient whose parent is bringing her in, complaining that she just really doesn't seem like herself, hasn't been that way for the past month. Patient is starting to refuse to come down and out of her room for family dinner. She typically really likes to go to soccer practice, but she's refusing lately. She started to have some academic changes. She's failed 2 tests, which she's struggled a little bit in the past, but really hasn't been this bad and doesn't seem to be having much motivation to change. She's also seems to be pretty snappish with her family. She's just really irritable. And she's also finding that she's having trouble falling asleep, and the parents are finding that she's kind of getting up and moving around at night because she can't sleep. And then mom kind of throws in at the very end, you know, something similar to this happened last year around the same time, but we kind of forgot about it because it kind of went away. So at this point, I'm a little confused, a little concerned. The patient seems to be having some behavior changes. She seems to be, her mood seems to be different, and she's having some kind of somatic changes as well, particularly with the difficulty sleeping. And then it's interesting that this has happened before, although it went away on its own. So let's talk a little bit about depression in general. So just to kind of start from the broadest picture, a lot of us are pretty familiar with major depression, but I wanted to go through the criteria. Of course, for any patient to be diagnosed with major depression, we talk about them needing symptoms for at least 2 weeks or more, and they need 5 or more of those that are listed here. And of course, one of those has to be either a depressed or an irritable mood, or and the irritable mood goes primarily for children, or decreased interest or pleasure in things that they would normally like, so not really enjoying things anymore. And then we have the kind of more somatic changes with appetite going up or down, sleep going up or down, physical movement maybe being slowed or sped up. And when we talk about psychomotor agitation or retardation, we really mean that it has to be observable by someone else, not exclusively a subjective feeling. Energy going up or down. And then we also have the kind of more emotional and cognitive things about the thoughts of worthlessness or guilt, impaired concentration, can't focus, and of course, recurrent thoughts of death or suicide or any suicide attempts. And of course, these have to be present for most of the day, nearly every day for that 2-week period. And what's really important is the distress or functional impairment. These things are really causing the patient to be functioning differently in their life, whether that's at school or at home or in relationships. And then, of course, it can't be due to some other substance use or another medical condition. So, of course, this is all about a change from how the patient was before. So, seasonal affective disorder, specifically, it's in a way, it's a little bit of a catch-all term. It's a term that's used, it's a little bit more general than just depression. It actually can apply to a depressive or a bipolar spectrum disorder that has some kind of a seasonal pattern to it. People use seasonal affective disorder colloquially. Usually they're talking about depression, but in this talk, I'll try to stick to saying seasonal depression just to be a little bit more accurate there. Oops, sorry. So seasonal depression really is just a subset of major depression. So it's really not terribly distinct, but it is a little bit more specific. So in order to kind of qualify for having that seasonal pattern, patients usually have episodes that start at a particular time of year and then get better at a particular time of year. I'm sorry, I went too far. Doesn't count if the mood change is due to something else that typically happens that time of year. So if a patient gets very, very stressed out, let's say around exam time or around the start of the school year every year, it probably doesn't count if the patient's mood change is really related to that. And if you were to remove the stressor, they would be able to say, no, I feel fine. So it really has to be kind of due to the time change in the year. The patients typically have to get full remissions at a characteristic time of year, and then they need at least 2 episodes over the past 2 years without any non-seasonal episodes. So our patient, our 15-year-old we discussed in the beginning, had just had the current what's probably an ongoing episode and then one before around the same time of year, so that might count. And then over the course of a lifetime, for someone where this has been going on for a while, they need to have way more seasonal mood episodes than non-seasonal ones. A little bit more about that. For most people, we think about depression happening in the fall and winter and getting better in the spring. And we think that's probably due to the decreased light that time of year. Of course, has effects on your circadian rhythm. Different people are more sensitive to that than others, and there are a bunch of different mechanisms proposed for why that is. Probably all of them are true in someone. It's probably a little bit of a heterogeneous diagnosis, probably coming from a lot of places, but some of the things have to do with release and sensitivity to melatonin, serotonin, dopamine, retinal light sensitivity. Also, vitamin D plays a role. With decreased sunlight, vitamin D levels can drop, and that may affect mood as well. So probably a little bit of all those things. Interesting to note, though, it doesn't have to be the winter. People can have these episodes in the spring or summer as well, and that is true for bipolar as well. But it can be true in depression. So just interesting to keep in the back of your mind. It doesn't have to be winter depression. Of all the DSM characteristics that we've mentioned, the two that seem to be the most seasonally affected are sleep and appetite. So if you have a patient who happens to be mentioning that they're just eating typically a lot more or sleeping a lot more or less during the winter, it might be useful to have in the back of your mind following up with some questions about their mood and their functioning overall, because that could be a piece of this. Seasonal affective disorder, or rather seasonal depression. There's a range of estimates of how many kids this affects, and it depends a little bit with age. Definitely gets more common as kids get older, but of course, so does major depression generally. It's more common after puberty. We see more of this at northern latitudes. The days are shorter, the temperatures are colder, so that makes a little bit of sense. And then it's a little bit more common in females than males. So as we're thinking about this, and you're trying to differentiate and decide in your office, you have a patient who's seeming like they have a pattern of doing a little bit less well in the winter. Is it definitely depression? So just to kind of throw out there, there's another diagnosis that you might consider using if the patient isn't having a lot of diminished interest or pleasure, if they're maybe describing some low mood, particularly if there's a particular circumstance that's happening. This is really particularly interesting right now during the pandemic when everyone has a lot of extra stressors going on. We use the term demoralization to talk about an understandable reaction to a troubling circumstance. So if it's proportional and it makes sense and they're not having that anhedonia piece, this might be what you're really thinking about. It might be useful in patients who are particularly those kind of preteens below mood and irritability. It's an ICD-10 code, but it's not a DSM diagnosis. And it's interesting in particular because we'll talk a little bit more about, when we talk about management, about the placebo effect. In depression, it's really, really large. And there are a lot of reasons that could be. One of them could be that some of the kids diagnosed with depression in those studies really could have maybe been tagged a little bit more accurately with a demoralization picture. But in any event, this is something to keep on your radar. A tangent off of that, or kind of a similar concept to that I see written about a lot, especially kind of in the lay literature, is parents talking about the winter blues. That would be, it's not a DSM diagnosis, nothing formal, but less severe form of seasonal mood change. So a kid may be coming in with low energy, increased appetite, their enthusiasm might be down, not as much productivity, but they're really not complaining that they're feeling fully depressed and they're still enjoying things. So that was sort of more helpful in terms of talking to parents if a patient really isn't qualifying for a full diagnosis. So I want to talk a little bit about how to go about diagnosing and who to screen and diagnose and assess in the clinical setting. So depression is definitely something that pops up. I want to talk a little bit about who should be getting just regular screening rather than just a focused exam if you already have concern. So the recommendation pretty much across the board at this point is that youth should be screened for depression starting at age 12. That's coming from the USPSTF and the guidelines for adolescent depression and primary care, the GLAD PC. So screening everybody 12 to 18. And the reason for that is because not only because the prevalence pops up of depression around about age 12. You can see from our bar graph here that the prevalence is going from below 2% up to about 6%. And then actually once you get up to your 20s, it jumps up to about 20%, which is a little bit closer to the lifetime prevalence for adults in any case. And of course, the other reason is it makes sense. This is when patients are starting to go through a lot of lifetime changes. There's hormonal changes, puberty begins, high-risk behaviors begin. They're shifting as far as their identity, starting to kind of identify more with their peers and their parents. So there's a lot of stressors going on. So checking to make sure that their mood is staying stable makes a lot of sense. As far as how often to do it, the recommendation is yearly, but there isn't a lot of data specifically saying that that's perfectly right. So of course, if you have somebody for whom you have any concerns, screening a little bit more often makes sense too. So what are you going to use when you're in the office? The two that I'll really talk about today are two that are kind of the most useful, the most prevalent, and you may be familiar with some of these yourself. Same tools for seasonal depression as for major depression generally. There are a ton of different screeners, but and I'll talk a little bit at the very, I'll also mention that there's another one for younger kids. Thank you for see that in the chat. So for kids ages 11 to 17, the PHQ-9 is a really common one that I do recommend. It looks at patients' symptoms over just the last 2 weeks. It's a total of 13 items. It is a self-report, so the patient's the one doing the reporting. And it's available for free online and also on the BHIPP site, thanks. So of course, this is, again, I say this is the patient self-report. So if you have a patient, just kind of thinking to throw out there, if you have a patient who has any kind of relationship or guardedness with their parents, you might make sure that they're able to kind of do this in privacy. But in any event, the items are scored 0, 1, 2, 3 based on how many days a week their symptoms are happening. It has pretty good sensitivity and specificity. If you take a cutoff score of 11, the sensitivity compared to one of the gold standard diagnostic depression interviews is almost 90%, and specificity is 78%. So that's pretty good. It can also pick up a little bit on patients who have had kind of persistent depressive symptoms over the past year. It does ask questions about functioning at work, at school, and home, and will help screen for suicidal thoughts over the past month. So here's what it looks like. Only the first 9 questions are the ones that are scored, and then they're just summed. And these are our score cutoffs that we use. So anybody above 10, you're starting to get more concerned, and of course a higher number basically means a greater severity of depression. So in a patient, who you're treating, it might be useful to get one at baseline and then repeat these later on down the line to see if the score has improved at all. So that PHQ-9 is for 11 to 17. If you have a patient who's a little bit younger, a tool that's validated for kids down to age 8 is the CESDC, which is the Center for Epidemiological Studies Depression Scale for Children. It's a little bit longer, a little bit more involved, a little bit less efficient in some ways, but I do like the wording of these questions, particularly for the younger kids, younger subset. It just looks at symptoms over the past week. And again, it's scored kind of 0, 1, 2, 3, and then more or less summed with a little bit of complication of reversing the scores for a couple questions. So there are directions involved. The scores go up to 60, and then we get concerned if patients are reporting a score higher than 15. There also is a tool for kids if you're concerned about a patient who's in the much younger age group, this 3 to 6 year old group, that might not be one that you would be screening routinely, but if you do have concerns or questions, the preschool feelings checklist is a good choice there. It's 16 items, and it's the parents' report rather than the patient's, and it's just yes or no questions and summed, and if there are more than 3 yeses, or 3 or more yeses, then you probably want to consider referring this patient. When we're talking specifically about seasonal depression, in addition to these screeners or before these screeners, I think some things you can kind of ask to get at that seasonal pattern if you're curious. So ask, in the winter, do you feel worse? In the winter, do you eat more or gain weight? Typically, that's the way that the symptoms go. Typically, people eat more and gain weight and sleep more rather than the opposite, although the opposite is certainly true. Do you feel like you have less energy? Do you feel like you're isolating from other people, not socializing? And kind of interestingly, do you feel like you get any better when the days are sunnier? And keeping in mind that to actually diagnose the seasonal subtype of depression, we're thinking of at least 2 episodes in the past 2 years. So we'll talk a little bit about screening, about treatment, and both from a pharmacological and non-pharmacological perspective here. So before we dig into the too far into the non-pharmacological approaches, I want to talk a little bit about treating depression kind of on a general level. There are a lot of things that happen in depression studies that account for this, but we know that in most studies of depression treatment, specifically for antidepressants, there's a really, really large placebo effect. You can see here that, apologies, my screen went back. In this report, the patients pooled together had a 50% placebo response compared to a 61% response for the antidepressant itself. That's a very large placebo response. It's larger than we get for some other mental health disorders, larger than you get in a lot of studies of somatic treatments. It's quite considerable. So the reason I highlight this is because it's probably true, and I would argue that this is a good reason to consider when you're managing depression. Remember that doing something is probably better than nothing. Intervening may well have a significant effect in your patients compared to non-intervening. So whatever treatment choice you choose, trying to follow through and be persistent with it is definitely desirable, and you may well have a good impact on your patient. So the point is just do something rather than nothing. So for starting to talk about non-medication choices, a few different things. We'll talk about active monitoring, we'll talk about the role of sleep, talk about a role for exercise, maybe a role for bright light therapy that you may have heard of as well, and then of course psychotherapy as for any depression treatment. So if we're talking about management, it's also important to talk a little bit about prevention. You've heard it a million times that kids really help routine. Kids and adults are really helped by routines. Having a consistent schedule for sleep, meals, work, and family time, things like that, really do tend to help. And that is super true when you're going into a season where you may expect a patient to struggle. We talk about trying to make time for healthy habits, so getting outside, keeping active, keeping consistent with your family. If kids are willing to do particular activities, that's a great place to go. We talk about keeping realistic expectations. For patients who struggle, particularly in the winter, it may not be possible to head off all of their symptoms and all of their dislike or all of their trouble with that time change, but it's definitely possible to kind of go into it if you have a history of these kind of seasonal changes, hoping to improve. And the other piece of it is that it's really challenging to come up with solutions sometimes, but if possible, getting the whole family, if the patient has a support structure, getting them to keep to the points above. So keeping the family to a routine if they're able. Is it possible to enlist the parents to have the kid do a game of basketball or take a walk at the same time every day? Keeping to a similar schedule for the family, if at all possible. Those are the kinds of things that will help support the patient through the season. Talking a little bit about active monitoring of patients. So the GLAD PC that we mentioned before mentions a few things kind of as general recommendations, talking about making sure that kids have access generally to mental health care within integrative or collaborative care settings. But they also mention that for mild depression, the first intervention maybe should just be active support and monitoring for 6 to 8 weeks, and then a little bit more intensive intervention and potentially mental health consultation if it's a little bit more severe than that. And of course, we recommend evidence-based treatments whenever possible. Active monitoring for your kids with mild, maybe moderate, but particularly mild depression may just involve increasing your frequency of visits. It may mean having an increased number of phone follow-ups between visits, particularly if they can't be seen in person. It may mean having educational materials available to patients and families so they have a little bit better understanding and can read up on what may or may not be going on. It may involve a little bit of prescribing, but prescribing things like exercise and fun activities. It's behavioral activation, which is a treatment for depression. It may involve prescribing something like a peer support group. So things like this may be enough for somebody with mild to moderate depression to begin to improve, mostly mild depression. Other interventions that may be useful across the board. We've talked about how sleep is something that changes a lot for patients with seasonal depression. There is a simple brief psychotherapy that is very well validated for adults for insomnia and has been adapted for use in kids, CBT for insomnia. Sleep hygiene counseling, something I'm sure a lot of people are familiar with. And it really does work, but it requires persistence and consistency, which can be the trickier part of things. Important parts to focus on are having a schedule for their awakening and having the patient wake up at more or less the same time every day. It involves trying to restrict sleep during the day, no naps. I know that can be a challenge for some patients, and restricting caffeine. And then trying to make sure that the bedtime location is absent of things like lights and electronics and music and things that could be stimulating. So we call that stimulus control. These are places where families can make interventions with pretty low risk. I want to throw in here, while we're talking about sleep, a little mention of melatonin, because it does come up a lot. I have a lot of parents ask me about melatonin. A lot of patients ask me about melatonin. And it's very, very commonly used. But I want to think about it a little bit if you're trying to help a patient sleep. Of course, melatonin is a hormone from the pineal gland that helps regulate our sleep cycle. Levels peak during the second half of the night. It doesn't take much given during the day to increase the blood plasma levels in a young adult. And at a high dose, it's a sedative. We know from adults, the data says that giving melatonin moves sleep onset about 30 minutes earlier. But if you continue to take it, the effect wears off after about 4 weeks. An important thing to remember is that over-the-counter melatonin preparations may vary a lot from what's on the bottle. There's a study that said that they can have anywhere from less than 83% less to 478% more of melatonin per pill than what's actually labeled on the bottle. And there are verified versions of this, but they tend to cost more and are only available in 3 and 5 milligram dosages. So for kids specifically, we know a lot of parents use it either with or without a recommendation. It has some efficacy data for using it for sleep in kids with autism, maybe a little bit for kids with ADHD. But we don't have a lot of information on using it in kids, particularly long-term. So for patients without those kinds of diagnoses, and particularly we don't know long-term safety. We do think that long-term use of it can suppress the hypothalamic pituitary gonadal axis, and that could even potentially cause delayed onset of puberty. So that may potentially be a big impact on a patient. So it may be a benign sedative for sleep onset, maybe for short-term use, but really overall, because of the caveats for longer-term use, if possible, using it only very sparingly or no meds at all would be preferred if possible. We've talked a little bit about exercise. There's good data that says exercise is associated with improvement in depression, and that's true for seasonal depression or kind of the more general type. We know it's really not easy to get a depressed patient to exercise, but if possible, it really doesn't matter what exercise they do. So if there's if the patient has any preference or any buy-in or anything at all that they're willing to do, it doesn't have to be a dramatic change. And it can be whatever they like. So something like a daily walk outside might be great, particularly if the family is willing to do that as a team. I want to talk a little bit about light therapy because I've definitely had patients and parents ask me about it in the past, particularly both with kids and adults, actually. So there's data for treating adults with light therapy. What light therapy is, if you're not familiar, is it's a fluorescent light box, essentially, that puts out white light. There's a UV filter on it, typically to prevent skin damage. For reference, the box is usually somewhere in the range of 10,000 lux, which is a measure of light brightness. A sunny outdoor day is 50,000 to 100,000, and sitting by a window is usually less than 2,500. So that just gives you a feeling for how bright these things are if you've never seen one. They usually typically sit a couple feet from your face, but it varies depending on the device. And in adults, the treatment that has been affected usually starts at using it for 30 minutes every morning, as close to awakening as possible. Sometimes patients need more than that. So that's a pretty decent time commitment, although the patient can be doing something else while they have the light shining in their eyes. In children, the data is a lot more limited. There are a few studies. They're honestly pretty, they're not brand new. They're the ones that I have found are, a lot of them are from the 80s and 90s, although a little bit more recently. It does seem to be pretty well tolerated. It may help modestly, probably more in seasonal depression, kids than non-seasonal. That time commitment of getting that light shining in the eyes might be prohibitive for some people. They typically cost somewhere in the range of $25 to $50. You can get one on Amazon that has these specifications, so that may be prohibitive to patients as well. But it does seem to be pretty well tolerated, with the caveat that if you have a patient where you're concerned for bipolar disorder, this might be something you want to avoid or have someone else recommend. Have them talk to a mental health provider first, because there is a small risk of triggering mania in those patients, but overall it's fairly safe. The other version of this is dawn simulation, which is a light that slowly turns on as the patient is waking up, a little bit brighter than the natural dawn, perhaps a little earlier. And that does seem like it may help morning awakening in kids. So it's not something I would prescribe as a first-line treatment in a kid, but if a patient is really curious and wants to try it, I think it potentially could be helpful without a ton of downside for most people. So I think Kelly was going to help me out here and talk a little bit about psychotherapy for depression, specifically CBT.
Sure, I'm glad to jump in and to join for folks that are not new to our BHIPP webinars. You know, we always add in something around kind of therapeutic, non-pharmacological treatment. So glad to do it. And I will be mindful of the time so we can get through our content. But we did want to speak a bit about CBT. We know that this is sort of the gold standard behavioral approach. And so wanted to give a nod to it, and we'll speak specifically about the highlighted components you see there. Primarily, we'll touch on a couple others, but some of the elements of the model. So psychoed, in this case about depression, although we know CBT can be used for anxiety too, behavioral activation and relaxation. And then we'll touch on a couple of the other pieces, but these components, we think you could pull out some sort of core components or maybe add into a brief intervention in the primary care office. So hope there are some takeaways there. Alden, do you mind advancing? I'm sorry, you have the slide control.
Yep.
Great. So when you're thinking about providing psychoed to a patient or a patient and family in the office, one of the elements that's really talked about is the cognitive triangle, and you see that illustrated here on the slide. And something that a provider or a therapist, depending on your role, would talk to the family about, or the adolescent, depending on how old the child is that, you know, your behavior, your thoughts, and your actions really don't work independently or exist independently, that they all work together. And so you could come up with an age-appropriate example, but the bottom line is it's hard to change your thoughts or your feelings or your behavior independent of the other, right? So you could think with them, like when a teenager is depressed, their thoughts, emotions, and behaviors, you know, you might find a downward spiral happening when a breakup happens or a bad grade happens, that you sometimes see that spiraling start to happen and thinking start to change. Like, I'm never gonna, you know, pass chem because I just failed that test and now, you know, I'm destined to never get into a college. You start to see these kind of thinking patterns happen. And on the flip side, you might see positive thinking happen, sometimes with some coaching or some work around this, right? Like, oh, I scored the winning goal in my basketball game, like, obviously I'm gonna get drafted, or right, whatever. So you can work in on the flip, and that's the goal of CBT, to help kids learn how these things work together, that our thoughts affect our emotion and behaviors, that positive thoughts or behavior can lead to good emotions and feelings like joy, and to help kids make that connection and identify thoughts and behaviors, and that also identifying when negative thoughts are happening, or negative behaviors are occurring, that can lead to negative emotions. So that's the point of the triangle. We have some resources around that and are happy to talk further at other times. Next slide, Alden. Thanks. So this is one we won't spend a ton of time on, but it is important when we're helping kids and adolescents understand their thoughts and feelings and behavior, is to track mood over time. And this is a really simple task. And Alden talked about kind of active monitoring. So for kids with mild or moderate depression that maybe don't need long-term treatment, or maybe aren't starting on a medication, understanding and tracking mood over time, understanding triggers can be helpful, but also this is used in CBT. So really learning how and helping kids pay attention to how they're feeling and what situations might lead to a change in that mood or them feeling more depressed or less depressed can be really helpful. It's also really easy to do. It's low cost, right, or no cost. I've drawn a lot of thermometers in my life and been made fun of by most of my child and adolescent patients for how bad they look. So, but it's really easy to do. And then you can help with some of that feelings identification, right, and thought identification. So this is something that can be done really quick in the office over time and done daily. And you can lead to further exploration of this, like what happened at that time, what led to that feeling, get additional details. And not just about negative thoughts, but of course about days when maybe their mood is sort of higher or more elevated. So you can practice those ratings and then do some kind of coaching for additional sort of homework or rating at home. It's something parents can do too. I think a lot of the kids we see tend to not have great kind of emotion language. So it's also some good practice for other skills. Next slide, Alden. Thanks. So behavioral activation. So we really want something the provider, therapist, pediatrician, whoever's going to be doing this. So if you take this home to add it into your toolkit, is that we want to identify with kids and adolescents some things that they enjoyed before. So if we have someone who is depressed and is maybe not doing as much of the things they previously did, hanging out with friends, playing a sport, whatever they previously enjoyed. Dr. Betancourt, who some of you might know, she says, you want to coach them to fake it till they make it. So help them think about what were some things that they did before their mood took a dip and was lower, and then get them to do some of those activities. So you can talk about that with them and their parents or their caregivers, whoever their kind of family system is, and what we know over time. This is just some good mood hygiene, which we always encourage, is to get them to do some of those activities, even in small bits and small doses. So maybe it's getting outside, maybe it's taking a walk, maybe it's going to the mall, maybe it's, I know some adolescent girls, it's maybe doing a face mask, maybe it's, whatever it is. But it's going to keep them busy. It might be engaging in something that does something positive for someone else. It might be, it's different for everyone. So identify a few of those, maybe 4, and then you can track that behavioral activation, kind of how they felt before, what they did, how they felt after. But it's, these are really pretty simple things. So we hope that's what you take away, sort of some mood hygiene, sleep hygiene, routines, and some easy things that you could pull out from this. Next slide, Alden. So, you also some problem solving skills. I think these are another takeaway, but they can be explored and they certainly go deeper in CBT. But as you progress through the model, we want kids and adolescents to be able to identify what problems they might be facing and then develop some skills to address those problems. So there are lots of acronyms, and you can find other versions of this or other sort of cutesy phrases, but this one uses steps. So they probably have shared with you what the particular challenges they might be facing with peers or with their families or academic challenges. So you might pick one to identify and then come up with some strategies to solve those problems. So hopefully they feel equipped to do that once they've kind of used some of those skills leading up to this. So think of some solutions. You're going to look at the problems, from a couple angles, some maybe good and bad aspects. Pick a solution and try it out. And maybe it's successful and maybe not, right? But that's part of the learning experience. Next slide, Alden. I'm trying to be mindful of our time. So then we also ultimately want to be helping the kids that we're working with do some cognitive restructuring. So likely the young folks that you're seeing tend to automatically have negative thoughts. And we want them to explore that and look at the evidence around that. Like, are there some other ways that they can think about that? Is it really realistically? We want to come with some evidence and be really objective in exploring those thoughts, because chances are things aren't quite as negative as they're perceiving them. So we want to help them do some exercises in exploring those negative thoughts. And again, this blue, just like steps, there are other acronyms and kind of worksheets that you could pull out to do this. But we want to help them think about whether the thoughts they're having are too negative to be true, because we know that blue thoughts make them feel bad, right? They would make us feel bad. So are they blaming themselves? Are they looking or seeking out bad news? Are they doing some kind of unhappy guessing? Like, I probably didn't get invited to this event that I saw plastered all over Instagram because I'm such a bad person. I'm so terrible to be around. Or was that just a last minute event, you know, that I happen to not be where, you know, wherever it took place? Or am I exaggerating? Like, you know, everyone else has X but me, or everyone else got an A on this test but me. So really to explore it from all angles and then think of a more realistic true thought. You know, some people have this, but not everyone, whatever. There's lots of scenarios I think you could consider with your adolescent patients. On the next slide, thanks. So here are just some examples of negative and unhelpful thoughts. The fifth one there, you know, really catches my eye. I think COVID has presented some unique challenges as we're supporting kids and adolescents. I'm not allowed to see my friends because of COVID. My life is horrible. So I, you know, I'll let you all continue and take us through that. But I do think we have some unique challenges right now over these last couple of years.
Exactly, it's very true. So moving on quickly here to pharmacological management. So what about the medicine side of things? When you do have patients who are kind of in that more moderate to severe range of depression, really a medication may or may not be warranted, particularly in conjunction with pursuing some of these other non-medication ideas, like in conjunction with therapy, in conjunction with some sleep changes, in conjunction with all those other things. So when making your choice, SSRIs are, of course, the medications that are have the most data as far as safety and efficacy in the pediatric population. So the three medicines that have that approval for that age group out of the SSRIs are Prozac, Lexapro, and Zoloft. So fluoxetine, escitalopram, and sertraline. You can see the indications and the age ranges there. Sertraline's indication is really for OCD 7 on up, but we use it really commonly for depression and anxiety in kids as well. There are some other SSRIs that you might see around as well: fluvoxamine, citalopram, paroxetine, the last one being Paxil. But there are some reasons regarding safety and availability that we don't use those as much. So in a primary care setting, those first three are really going to be your kind of workhorses. What's the difference between the big three? So Lexapro is a really common one. The dosing is basically either 5, 10, or 20 for most people, and that's sort of the max. So it's fairly simple dosing. It doesn't interact very much with other medications, which is nice. The nice thing about that dosing is that for a patient, if they're a little bit older and they're starting on the 10 milligrams and then planning to go up to 20, they can go home with just one prescription for 20, break it in half, and then go, and then after a while, start taking a whole medication. So that's pretty simple. It tends to be less activating than some of the others, so meaning it doesn't interfere with sleep as much. Sertraline is also, very useful. It does have some interactions through the CYP450 pathway, but it does have a wide dosing range. So if somebody has severe depression and you're worried they're going to need to go up and up a little bit, that might be a reasonable choice. Anecdotally, I do find that, and I've talked to other people too who find Zoloft sometimes has a little bit more GI disturbance than some of the others. But that's sort of anecdotal, and it does tend to get better over time. And then Prozac is the fluoxetine is the SSRI we really had of these that we've had around for the longest, have a lot of data on. It sticks around for a really long time in someone's body, so that's good to keep in mind. The half-life is even up to several weeks, up to 5 weeks. So if you're stopping that medication, you don't really have to taper too much because it'll self-taper. It does interact with a lot of other medications through the 2D6 CYP450 enzyme. So you do want to kind of run an interaction check if you're considering starting this on a patient who's on a lot of other things. And it also tends to be pretty activating. So giving, increased energy, maybe agitation, maybe insomnia. So keep your eyes on that. So general principles of, and of course I'm trying to keep an eye on time as well. General principles, we've heard a lot, start low, go slow, but emphasis on not too slow. So for patients, it's important to start an appropriate dose for their age and size, which we'll talk about in a sec, but we don't want to leave them at a starting dose if they're not improving for too long. So for sake of reference on how much to expect with your patients, a stimulant for an ADHD, just for comparison, has an effect size of 1. SSRIs for depression have an effect size of about 0.2 for depression, just because there's such a high placebo response rate probably, and then a little bit greater of an effect size for anxiety. The side effects that you experience with these things, there definitely are some, but a lot of people don't have any, and what do occur typically reverse if you stop the SSRI. So that can be reassuring to patients and parents. Now, it does take up to 4 to 8 weeks to get to the therapeutic effects of a given dose. So it's important to remember that these are not something that may change the patient's life overnight. And then one thing to think about is potentially getting a screening lab of a TSH before starting an SSRI, partly because low thyroid problems can contribute to mood problems in the first place. And also there might be a little bit of an impact of an SSRI on someone's thyroid functioning, just a little bit. So that's a potential. As far as dosing for sertraline, we tend to start teens at 25 or 50 and children at 25. Fluoxetine, kind of more 10 or 5 for the teens and children respectively, and then escitalopram 5 or 10 for the teens and 5 for the little kids. And you can see kind of what the dosing increments are. Typically, the maximum dose for an adult for sertraline is 200, and it's going to be kind of proportionally lower for a smaller child, and same for all of these other medications. Fluoxetine has a star there. We do use higher doses of fluoxetine for bulimia nervosa, and sometimes patients may need to go up to something like 40 milligrams in a child, but really beyond 40 milligrams of fluoxetine, I wouldn't do in a primary care setting. So in any case, this kind of gives you a sense of where we stand. And we're, BHIPP, I know I do a lot of consultations where we're talking about dosing, so that's something to help with as well. Dose equivalencies, intercomparing, just to give you a sense of fluoxetine, how they compare to each other. Fluoxetine 20 is about sertraline 50 and Lexapro 10, although those can vary a lot. A lot of times maxing out a dose, though, it's important to remember, may give you more side effects than responses. So most people do the best with their mood and the least side effects at kind of a moderate dose of a lot of these. We've talked about side effects. There can be some things like nausea, things like being activated and agitated. It is important to remember that they all carry a black box warning for suicidality in patients 25 and younger than 25. But that's really about 1 in 100 patients, and that may just be due to patients with pre-existing depression and suicidal thinking suddenly getting a little bit more activation, a little bit more energy and able to act on things. But in any case, what we mostly do is if you're concerned, you discuss this with the family and the patient, and you discuss what you're going to do to mitigate that risk. So we're going to talk about, monitoring, checking in with the patient, making sure the patient knows to report anything new or different. Patients can have sexual side effects that are there, and then these can also affect patients who are pregnant. So if you have a patient where pregnancy could potentially be something that's on the table, you would want to talk about that before you start an SSRI. And I'm happy to answer more specific questions about that too. Serotonin syndrome is a concern that comes up a lot. It's not terribly common, but it's going to be more common in patients who are taking over-the-counter supplements like 5-HT or if they're taking triptans for migraines. What that looks like tends to be agitation, mental status changes, feeling confused. They may have vomiting or diarrhea or nausea. They might be sweating. That hyperthermia is a big one. If you have a patient whose temperature is going up and they're experiencing a fever recently after starting an SSRI, that might be something to be concerned about. If they have a tremor or feel rigid, those are things that need, if there's concern for this, the patient really may need an emergent evaluation, especially if more than one of these are present or if anything's really acute. So that'd be something to counsel the family on, although it's not common. Stopping these medications, stopping them too abruptly can make people feel pretty uncomfortable. So definitely would want to taper, with the exception of Prozac, which you might not need to taper too much because it kind of self-tapers over time. But that would be flu. People can be irritable. They can be more anxious if you stop it too quickly. They can feel like they have the flu and have GI symptoms, things like that. So that's important not only to think about when stopping a medicine in one of your patients, but also to counsel the patient not to stop it abruptly themselves. Because they may not feel great, and they may come to you and ask why they feel not so good after they stop their medicine. Just really quickly, a few other medicines that you may come across your path. These are other kinds of antidepressants, SNRIs, and medicines in their own categories. They don't all have as much data in child use and may have more side effects. So that's why we don't tend to recommend them as sort of the first line. Duloxetine and venlafaxine are serotonin norepinephrine meds. Bupropion functions a lot similar to an amphetamine, has norepinephrine and dopamine effects, and can have a high seizure risk. So if you have a patient with a seizure history, that's not something you want to use. And then these other medications, Remeron is an antidepressant that works on serotonin, but can be really sedating, which can be good for somebody who doesn't sleep, but also increases appetite and causes weight gain a lot of the time. And then Lamictal you may see as well, but that's a tricky medicine usually used for bipolar depression and needs to be titrated really carefully because it can cause a rare fatal rash. As far as monitoring, these are kind of recommendations from ACAP, which is our academic body. These are our kind of practice parameters and sort of best practices sort of idea. Assessing clinical response of a new medicine at 4-week intervals, so every 4 weeks. So maybe not expecting a medicine to make a massive change in just a week or two, but it sort of depends. On the flip side, but if a patient has been on a medicine and maybe titrated a little bit over 8 weeks, but really hasn't gotten any benefit at all, and particularly at a therapeutic dose, and they haven't gotten any better, they may need another treatment. And the goal really should be remission at 12 weeks. So if the patient isn't doing at all better at that time, they really definitely need an alternative treatment. So FDA does recommend, particularly for patients with depression, that after you start a medication, you should see the patient every week for the first 4 weeks and then every other thereafter. And they recommend to do a telephone visit, if not in person. However, there's no data really about whether doing it that way impacts the suicide risk. So this would be something to keep in mind, especially if you're concerned about safety in your patients doing those kinds of more frequent check-ins. But we understand that circumstances may vary a little bit, but definitely factoring in are there ways to make sure that the patient is being monitored appropriately in addition to your telephone visits, so family check-in, school check-in, things like that. And that's all I have right now on the pharmacological side of things for depression. So I'm happy to take any questions. I know there's not a ton more time, went a little over.
Thank you so much. I will try to look at the chat here. Here we go. Chelsea or Rebecca, I know you've also been monitoring the Q&A section in the chat. So I will also let you jump in if you've seen anything come in, but please feel free to let us know if you have questions. I saw a thank you pop in. I will be very candid though. I see the chat, but not the Q&A, Chelsea. So if you don't mind checking that.
Sure, Kelly and Dr. Littlewood, we had a question for seasonal, for SAD, would you use an SSRI seasonally?
So it really, so it depends. For me, I potentially would. It depends on the severity. So I think the question is asking, would I plan to start the medication and then just plan to stop? I think it depends on the level of severity of the depression and how good a history we have that the patient tends to remit on their own. If the patient has had several episodes and it really does remit pretty well, pretty consistently, as it should according to the criteria, then I might consider just using it for the season. If it's a little bit of a murkier diagnosis where maybe it's gotten worse in the winter, but maybe we're not entirely sure that it went away on its own, I would really follow that a little, expect that I'm going to need to assess clinical response, see if they got better on the medication, make sure they're pretty stable and doing well. and leave it there for a little while, weeks to months, before I start to potentially stop the medication. I hope that answers the question. Sort of, it depends.
Thank you. I will admit, I still can't see the section. Oh, I see it now. I see where that was, Chelsea. Any other questions? I see a few thanks coming in, so I think you hit the right note with the content. Any other questions from the group? Thank you, Rebecca. I see you've answered some logistic questions about where to access the recordings and certificates. Okay. Well, if folks do have questions or have specific cases that come to mind, you can always call the BHIPP consultation service and speak to Dr. Littlewood or another physician consultant. So you can always keep that in mind. I know Rebecca added information about how to reach out to our team. So thank you for joining us today, and we look forward to connecting with you.
Thank you, everyone.
Thank you. Appreciate the presentation.